In fact, I think things have become much easier now. We have so many better drugs, such good monitoring. It was a huge challenge when we
started. So much safer.
Absolutely.
Absolutely.
With your finger on the pulse over here and God above, that's all you had to save you. They have become very,
absolutely. No, it amazes that, you know, during our formative years, we have done pediatric neonates with just one ECG monitor.
And a hand on the pulse, that's all.
And the esophageal stent in our ears. As PGs, as residents, I remember we used to only
putting
have
our stent in the,
yes,
and the precordium and monitoring, yes.
And we would be sweating because the temperature would be so high in the OT.
Yes.
That we still do.
That we still do, yes.
Yeah. No, but now we have very good warmers, right? So
warmers, we keep switching the AC on and off in between.
So should we start, sir?
Yes, yes. Ma'am, I think we can start now.
Good evening, everyone. So we have again come up with a new series of webinars on pediatric anesthesia. So this is one of them. We will be discussing about fluid and sedation, because these are the important topics, kind of is essential for all anesthetists, and these are tricky things because fluid management still is a question mark. So when we were students, we were not sure what fluid to give, how much to give, and still it is the same. And sedation is the most difficult part for anesthetist. You will be discussing in the lecture. So before we go forward, so I'll request Dr. Major Sethi to start the webinar and take the proceedings forward.
Thank you, Dr. Nishkash. Good evening, ladies and gentlemen. And before I start the proceedings, may I request Dr. Indrani ma'am to say a few words, please?
Good evening, everybody. Back to our fortnightly program, and I'm really looking forward to this one because pediatric anesthesia is so close to my heart. And the topics chosen are also very much the in thing, what one should know. And the one on procedural sedation, especially, you know, back as we were just discussing what we used to do in those days. So back in those days when we used to give procedural sedation for para or, you know, for pediatric dentistry and all that, you know, we had nothing except ketamine. And when it comes to monitoring, little said the better. So, you know, we went through a system which had absolutely no safety. And from those days to the present day today, when everything is sorted, like who should be giving the procedural sedation, whether it is a pediatrician, whether it is an anesthesiologist. So everything is sorted, and even systems for maximizing safety, all that is spelled out today. And now we have guidelines to follow for procedural sedation in pediatrics. And coming to perioperative fluid therapy, another very important topic which one should know, because what is true with adults is not true for the kids. So what is the difference between adults and kids, and why we give, what fluid do we give, how much we give? All these, I think any anesthesiologist who's giving anesthesia to the pediatric age group should have this knowledge. And I welcome all of you for this webinar and have a fantastic time and looking forward to this. Thank you so much. Long live RSACP.
Thank you, ma'am. Thank you for those kind words and those words of wisdom. I once again welcome all the senior faculty, the faculty and the residents who have joined us, and let's go straight away to our webinar. So we have two common everyday topics in pediatric anesthesia today. They are of concern to all of us who care for children in the OT. Dr. Ranju Singh will be speaking on procedural sedation in children, while Dr. Manish Gupta will be addressing the vexing problem of perioperative fluid therapy in children. Dr. Ranju Singh is Director Professor at LHMC. She heads the Pediatric Anesthesia Unit at LHMC and Kalavati Saran. She's also the President of IAPA Delhi chapter. She's a devoted teacher, a prolific scientific writer, a skilled orator, and simply wonderful with children in the pediatric OT. I'm sure we're in for a treat. I invite Dr. Ranju to speak on procedural sedation in children.
A very good evening to everyone. Thank you for those kind words, Sethi sir. And thank you, RSSCP and Indrani ma'am and her team for giving me a chance to talk about something which is so close to my heart. Pediatric sedation has actually seen a sea change in the past couple of years. And let me share my screen before I start my presentation. Just give me a second, please. So that's visible to everyone. So the procedural sedation today is a multidisciplinary field, and it spans a global practice across a variety of settings. We'll be talking about pediatric sedation in a number of headings. The learning objectives of this talk include the definition and goals of pediatric procedural sedation, discussing the patient evaluation, the equipment required, the personnel, and the monitoring requirement for procedural sedation in a pediatric patient, outlining the medications required, reviewing the potential adverse events, and enumerating a few non-pharmacological interventions. Now let's begin with the definition of pediatric sedation. This is the use of anxiolytic, sedative, analgesic, or dissociative drugs to attenuate pain, anxiety, and motion, to facilitate the performance of some necessary diagnostic or therapeutic procedures while providing an appropriate degree of amnesia or decreased awareness and ensuring patient safety. The pediatric sedation include guarding the patient's welfare and safety while minimizing physical discomfort and pain, to control the anxiety, minimize the psychological trauma, and maximize the amnesia, control the behavior and movement to allow the safe completion of procedure in children, and eventually to return the patient in a state from which safe discharge from medical supervision is possible. The intent of the physician is to achieve these goals while ensuring that the patient is able to independently maintain oxygenation, airway control, and cardiorespiratory function. An increased number of diagnostic procedures today has really increased the scope of pediatric sedation. And because there is a limitation of the availability of anesthesiologists, you have a large number of non-anesthesiologists performing procedural sedation. Is there any difference between procedural sedation and general anesthesia? Yes, there is. Procedural sedation is intentionally targeting a state in which the protective airway reflexes are retained, per se in the definition of procedural sedation, there is retention of airway reflexes of the patient, whereas general anesthesia denotes a state in which they are, by definition, absent. Unconsciousness without response to painful stimulus is not a targeted endpoint in either moderate or deep sedation, whereas consciousness without response is a targeted endpoint when you deliver general anesthesia. Airway maneuvers are generally absent in pediatric sedation, that is procedural sedation, whereas bag mask ventilation, laryngoscopy, insertion of a supraglottic device, and other airway maneuvers are usually an integral part of general anesthesia. And it has been seen that complications such as aspiration usually occur at the time of this airway maneuvering. Potentially emetogenic inhalational anesthetic agents are not routinely preferred when you proceed for procedural sedation. However, general anesthesia involves use of inhalational anesthetic agents which are emetogenic. In procedural sedation, most procedures would be relatively brief, whereas time constraints are not a concern when you are delivering general anesthesia. The indications for procedural sedation are today very wide and encompass multiple specialties. But I have divided the indications into three main categories: diagnostic imaging, painful diagnostic procedures, and painful therapeutic procedures. The diagnostic imaging procedures probably require sedation only. These include the interventional radiology procedures. Painful diagnostic procedures require both sedation and analgesia and involve procedures such as lumbar punctures, bone marrow aspirations, or even cardiac catheterization. Another category of procedures which require both sedation and analgesia include the painful therapeutic procedures such as management of fractures and fracture dislocations, laceration repair, burn care, or foreign body removal, dental extractions, ICD insertion, abscess, incision, abscess, drainage also are part of this category. Now, what are the levels of sedation that we are talking about here? These can range from moderate sedation to deep general anesthesia. Now, moderate sedation is a term which was previously known as conscious sedation, but we no longer use the term conscious sedation. And moderate sedation is defined as a drug-induced depression of consciousness during which the patients respond purposefully to verbal commands. Deep sedation, on the other hand, is a drug-induced depression of consciousness in which the patients cannot be easily aroused, but they do respond after repeated or painful stimulation. Dissociative sedation is a trance-like cataplectic state which is characterized by analgesia and amnesia with retention of protective reflexes. Therefore, in moderate sedation, generally no intervention is required to maintain a patent airway, spontaneous ventilation is adequate, and cardiovascular function is usually retained. Deep sedation, as we've said, is a condition where the ventilatory function may be impaired. Patients may require assistance in maintaining a patent airway. Spontaneous ventilation may also become inadequate and cardiovascular function is maintained. General anesthesia at one end of the spectrum is characterized by loss of protective airway reflexes. The patient may not be able to maintain a patent airway. There is depression of spontaneous ventilation because of drug-induced depression of neuromuscular function, and cardiovascular function may also be impaired due to the drugs which are used to ensure general anesthesia. This is actually a continuum. From moderate sedation to general anesthesia is a continuum, and many a times the children will pass from a state of moderate sedation, which was intended, to a state of deep sedation or general anesthesia, which is actually unintended. So how do you proceed about giving procedural sedation? Before you take up any patient for procedural sedation, it is necessary to evaluate these patients. As is with every case, a detailed history and physical examination needs to be done. Do assess the child for the presence of any respiratory illnesses, any fever, medication or allergies the child may have, any adverse reactions if already existing or history available for previous anesthetic exposure must be taken. This includes previous history of any airway difficulties if the parents can give. A history of snoring is extremely important while administering procedural sedation. Any major illness, any neurological abnormalities, any physical abnormalities must be taken into account. And of course, you have to take the history of the last oral intake. Physical examination should be focused to give you relevant information that will be useful when delivering pediatric sedation. The assessment of the cardiorespiratory status and volume status, and a detailed assessment of the airway, including the anatomy and functioning of the airway, is part of the general physical examination and a focused airway examination. So why are we talking about this? Is this the same as that for any general anesthesia? What I wish to emphasize for everybody listening is that the detailed examination of a patient before you deliver even moderate sedation is actually not different from how you will evaluate a patient who will be given general anesthesia. Is there any contraindication? Are there any exclusions to this? Yes, if you identify that the patient has a difficult airway syndrome, has history of sleep apnea, moderate or severe tonsillar hypertrophy, there is history of stridor or severe asthma, any tracheal abnormalities, a sick patient who falls into ASA category 3 or 4, patients who have severe gastroesophageal reflux history or some evidence of bowel obstruction, children who are obese, who have evidence of raised intracranial pressure, any neurological impairment, bulbar dysfunction, severe behavioral problems, and generally children less than 6 years old are also the children who are at an increased risk of experiencing adverse events during the sedation. And these are the children for whom you either must have an anesthesiologist on board, or at least a person who is capable of taking care of pediatric emergencies should be on board before you administer procedural sedation to these high-risk category children in the periphery. Now, fasting guidelines over a period of time have changed. All of us who deliver pediatric anesthesia now know that consequences of prolonged fasting can be severely detrimental in children. Over a period of time, we have progressed further and we have stopped fasting the children who come to us for anesthesia for prolonged periods, very well realizing that prolonged fasting can cause irritability, dehydration, and hypoglycemia in small children. Moreover, fasting does not guarantee an empty stomach. And there are many studies which show that there is no observed association between the perceived risk of aspiration and the pre-procedural fasting state. However, even today, fasting before elective sedation generally follows the same guidelines as for general anesthesia. But many studies done in the emergency department today show that the probability of clinically important pulmonary aspiration during pediatric procedural sedation is actually negligible despite variable fasting periods. There's a whole lot of literature available which talks about the sedation and fasting. We fast the children. Right from in the past 20 years, probably innumerable studies have talked about the adverse events in children undergoing procedural sedation, particularly focusing on the risk of aspiration. And what these studies have actually concluded is that the current concerns about aspiration are actually out of proportion to the actual risk. The aspiration, as per these studies, during PSA appears to be rare, idiosyncratic, and typically benign. This is a very interesting study, which is a report of the Pediatric Sedation Research Consortium, which talks about the major adverse events and the relationship to the NPO status in pediatric sedation outside the operating room. The Pediatric Sedation Research Consortium consists of 42 participating institutions, and these authors evaluated the aspiration episodes and the combined outcome of major adverse events, which were defined as aspiration, apnea, unplanned hospital admissions, and cardiac arrest. More than 139,000 patients were studied. It was observed that propofol was the the drug which was used for sedation in these children. And across so many patients, only 10 aspirations were reported. 75 major complications were reported with 0 mortality. So the authors concluded that aspiration is uncommon, and more importantly, the NPO status is not an independent predictor of major complications. This study was followed by an international multidisciplinary consensus statement that came out in 2020 that talks about fasting before procedural sedation in children. In this, the patients were risk stratified during their pre-sedation assessment based on a consensus-derived algorithm. Depending on the factors related to patient characteristics, comorbidities, types of procedures, and nature of the anticipated sedation technique. This is the first document which talks about fasting-related issues specific to procedural sedation. Fasting precautions for liquid and solids were then recommended for elective procedures upon categorization of the aspiration risk as negligible, mild, or moderate. This is the table that is there in this study, where the risk factors for aspiration have been categorized as negligible, mild, or moderate. Those patients who have moderate risk factors are fasted prior to sedation as per our general anesthesia protocol. That is, they are fasted 4 hours for breast milk and 6 hours for non-human milk. Those patients who have a mild risk for aspiration are fasted for 2 to 4 hours, depending upon what they have consumed. What is important to note is that patients who are categorized as having negligible aspiration risk can take unrestricted clear fluids prior to procedural sedation. But these categories are of those patients who do not have any known factor that increases the risk of aspiration. No airway manipulation is expected to take place in these patients when they are administered sedation in the periphery. So which are the patients who are at an increased risk of developing aspiration in ASA? Greater comorbidities, that is ASA grade 3 or 4 patients, infants less than 6 months of age, those who have airway abnormalities, who have history or evidence of obstructive sleep apnea, severely obese children, those who are scheduled to undergo esophageal endoscopy or bronchoscopic procedures, and those who have evidence of bowel obstruction. These are the patients who are at a higher risk of developing aspiration and may be fasted for a longer period of time. And it is these patients where, besides the sedation which is envisaged, probably additional techniques for achieving analgesia can be instituted. And the use of agents with less risk of depressing protective airway reflexes is recommended. Now, we must remember that sedation is a continuum, and it is difficult to predict the response to a specific sedative event. Which personnel can deliver sedation? Even in that brief introduction, Indrani ma'am mentioned this very, very important point about who can administer sedation to children outside the theater. Anesthesiologists are not enough to cover every area where pediatric sedation is given. The availability of better monitoring equipment and better drugs has made it possible for other people to bravely give sedation in areas where they were not giving sedation to children earlier. We must remember that apart from minimal sedation delivered to children, ideally, all levels of sedation require at least 2 healthcare professionals. Which are these 2 people who can deliver sedation to children outside the OR? One of them should be competent in managing the pediatric airway. This is the person who actually administers the sedation. He should be well equipped in recognizing the obstruction of the pediatric airway and instituting remedial measures. Should be proficient in providing pediatric resuscitation. should be able to take a difficult vascular access, should know which physiological parameters to monitor and when to raise a red flag, when to call for help, when to raise an alarm, and should be able to monitor the levels of sedation in that child. Be well familiar with the pharmacology of drugs that is used to give procedural sedation, and should be proficient in the recognition and treatment of the complications of sedation in children. The second person, other than this one who administers sedation, should also be proficient in providing resuscitation measures if required, and should be able to monitor the physiological parameters of the child. And of course, other than this, you require nurses and technicians in the team who deliver pediatrics. What equipment are required? Emergency sedation resuscitation equipment should be available for the pediatric patient. Now, you may have a whole lot of equipment, but when you run to get just a simple airway, nasopharyngeal, oropharyngeal airway, it may not be of the appropriate size. You may have a defib or an AED available, but if you don't have the appropriate pediatric sized pads or other equipment related to pediatric resuscitation, it is futile to have that equipment in that area. Many of us are familiar with this mnemonic SOAP-ME, which beautifully outlines the emergency equipment which is required in every area where pediatric sedation is delivered. Suction catheters of appropriate size, a well-functioning suction apparatus, adequate oxygen supply with functioning flow meters, the airway of devices such as oropharyngeal, nasopharyngeal airways, laryngoscopes, different sizes endotracheal tubes with stillets, different sizes of face masks and supraglottic devices should be present. Whatever drugs you are using, if possible, the antagonists for them should also be available. Monitors of appropriate size should be available, and extra equipment which you may require, like trolley support, should be there in the area where pediatric sedation is being delivered. Yes, this list is comprehensive. It looks simple, but what happens in an area where pediatric sedation is given? Usually these areas are outside the theater, and a new person may be going there every day. You may have a new team of residents. You have told one person one day, you tell the next team the next day, and when you come on the third day, you again have a new team who are probably clueless about what needs to be taken care of. To take care of this discrepancy, it is necessary to have checklists. There's no need to go keep telling them over and over again. Put up a checklist on the wall and make sure that it's ticked every time pediatric sedation needs to be delivered in that area. Most important, other than this, is an immediate access to emergency support, emergency help should be available. So where will the backup come from? Who will come to help? Where should the phone call be made? It is necessary to outline all these things in areas where pediatric sedation is delivered. How should the patient be monitored? There are beautiful guidelines now available from the American Academy of Pediatrics, which talks about pediatric sedation. And the guidelines have been established by the work group on sedation. Most important out of this is the direct visualization of the patient during the sedation procedure. There is absolutely no replacement for this. You may monitor the weight of the patient and note it down prior to starting the procedure, because this is required for drug dosing in small children. Note down the baseline arousal state of the child and the basic physiological parameters such as heart rate, respiratory rate, and of course, blood pressure at various intervals. Continuous monitoring of SpO2 is now recommended. What I wish to highlight is that SpO2 is definitely important for monitoring oxygenation, but it has been outlined that its use is limited due to delayed detection of hypoxemia during procedural sedation. Yes, you administer oxygen, but if the patient is becoming hypoxic, the detection may be delayed. It is very essential, therefore, to continuously monitor the child physically. A detailed documentation is important before, after, and during the procedure. Appropriate consent must be taken from each child's guardian. Instruction and information should be there to the responsible person in document that these adverse events are expected and they understand how the child will be monitored after the procedure is over. Infants and toddlers who are transported home after the procedure in a car seat may require slightly longer observation, because when they sit in a car at the back seat or even in a specially constructed seat for children, they tend to have airway obstruction because the head is moving forwards. These children need to be absolutely awake before you send them away after the procedure. Is capnography part of the management protocol? Should you monitor capnography in all these patients? Real-time detection of hypoxemia with capnography is today recommended. We are all familiar with the use of capnography in ORs, but it is still not a standard of care for sedation outside the OR. It is now recommended that capnography be considered for all pediatric patients undergoing procedural sedation outside the OR. It serves as a useful adjunct to pulse oximetry and to clinical assessment, and has been shown to detect hypoventilation and apnea much earlier than SpO2 and clinical assessment put together. When supplemental oxygen is being given to the child, capnography will facilitate recognition of apnea and airway obstruction several minutes before detected by pulse oximetry. You can easily put the sampling line close to the nares under a face mask or a nasal hood. Nasal cannulae today are available that allow simultaneously delivery of oxygen and measurement of EtCO2. This is a very nice study which talks about end-tidal CO2 monitoring during department procedural sedation and talks about the incidence of hypoxic events. The study looked specifically at capnography for detection and intervention for hypoventilation, and the authors observed that capnography identified all cases of hypoxia before onset with a sensitivity of 100%. It is therefore recommended by these authors that addition of capnography be made to standard monitoring to provide advanced warning for all hypoxic events in children undergoing procedural sedation outside the theater. These pictures will show that you can simultaneously deliver oxygen and monitor CO2. We can always easily do it in the intubated children in the theater. But what about those children who are undergoing procedural sedation? Effective oral and nasal sampling can take place even at low tidal volumes with no dilution of waveform during oxygen delivery with these devices, which are very, very easily available in the market. On the right-hand side, in fact, you can see a face mask through which very nicely sampling of EtCO2 can take place. How do you monitor the level of sedation? Yes, we are monitoring the physiological parameters. We are monitoring continuously SpO2. We've also said that we need to monitor the EtCO2. But what about the level of sedation? Does that need monitoring when you're delivering sedation to children outside the theater? Yes, you need to have assessment of the monitoring of the sedation level, because it is very, very easy for the children to pass from a moderate level to a deeper level of sedation. Traditionally, Ramsay sedation scale was considered as the gold standard for clinical assessment of sedation, but it is not specific for children. So the University Michigan sedation scale has been used in many children undergoing sedation outside the theater. What is the caveat for these assessment tools is that many of these are based, like Ramsay sedation score, are based on adult patients, may or may not be validated in children. The assessment is still subjective, and the readings may not correspond well with many drugs which you deliver for sedation outside the theater. And these sedation scales cannot reliably distinguish between moderate and deep sedation. So is there a way out? Yes, we are all familiar with the use of BIS, and studies have taken place to find out the utility of BIS in pediatric sedation outside the theater and correlation of the BIS with standard sedation scales such as the Ramsay sedation scale. This study in clinical radiology way back in 2004, in fact, by Bell et al., the relationship of BIS monitoring with the Ramsay sedation scale, and correlated that a Ramsay sedation scale of 3 and 4 corresponds to a BIS of 80 and 87 respectively. But these authors were of the opinion that BIS monitoring may, according to them, may provide useful information only when used with drugs like propofol. And over a period of time, more and more studies have taken place. As of now, majority of the studies are still lacking in definitive evidence that there is a clinically significant advantage of BIS compared to conventional monitoring in patients undergoing PSA, especially infants. We of course know the advantage of BIS, but still when I was trying to search through literature, there were not very many studies which definitively said that yes, BIS is an extremely reliable monitor for sedation levels in children outside the theater. It can tell the difference between GA and mild sedation, but may not be able to decipher varying levels of sedation with any great certainty. It, of course, serves as an adjunct to subjective assessment. This is what a standalone BIS monitor looks like and can be put in situations where sedation is given outside the theater. Should all patients receive oxygen? An important and contentious question which I will try to answer through a couple of studies which I came across. This study talks about the ability of pediatricians to recognize the onset of apnea in a simulated scenario where sedation was delivered with and without use of supplemental oxygen. And irrespective of the use of oxygen, it took more than 1 minute for the subjects in this study to recognize apnea. Hypoventilation and apnea detected more quickly when patients breathe only air, and supplemental oxygen does not prevent oxygen desaturation, but may delay the recognition of apnea. However, in spite of this, the authors concluded that oxygen prolongs the time to desaturation when hypoventilation occurs. So in spite of the fact that delivery of oxygen may delay the detection of hypoxemia, because it is such a safe thing to do, and because children do become hypoxic and you may not be able to detect it, it is recommended that patients under sedation should always be monitored by personnel who can recognize hypoxemia, and if possible, should be given supplemental oxygen when sedation is delivered outside the theater. Now, I've tried to focus the presentation on a lot of practical issues instead of just focusing on the drugs which we use for sedation, because that is a more theoretical issue. I'll just very briefly discuss what are the current concepts in drug delivery for pediatric sedation. We are all very familiar on what an ideal agent should be. Of course, it should have an early onset, should be rapidly acting, should provide very rapid recovery if possible. You should be able to target the depth of sedation very precisely. And the choice of drug actually depends on a lot of factors. Many of them are patient-related factors, which include the comorbidity that the patient is suffering from, the age and developmental level, the degree of anxiety, any particular problem with a specific medication that the child has reported. Also, on the degree of pain the child is likely to experience in that procedure, the type of procedure that is intended, and what is the amount of motion that is allowable in the child. More important than any of these is the skill of the practitioner. He's the one who decides whether the procedure will end up being safe or not for the child. There's a whole lot of drugs available together, in combination, by themselves, in different dosages for pediatric sedation. And this is an update on the pharmacological agents which are used for pediatric sedation. What this document basically tries to tell us is that, one, you should start with the lowest dose of the drug, use the drugs with the highest therapeutic index, give dosages and top-ups with at least a couple of minutes between each bolus, and allow the drug to have its maximum effect before repeatedly giving more boluses and loading the child. The potential for an adverse effect automatically increases when more than 2 sedative agents are used. We all know this fact that ketamine is a very popular drug used by non-anesthesiologists outside the ORs, but slowly propofol and dexmed are also gaining popularity for pediatric sedation delivered by non-anesthesiologists outside the theater. This is a paper we published from our institution in pediatric anesthesia a couple of years back, which talks about midazolam as a sole sedative for CT scan in pediatric patients. We had used midazolam in slightly higher dosages and realized that probably if you give enough time, midazolam by itself may be enough to provide sedation in a large number of pediatric patients who are under non-painful procedure like CT scan. Currently, dexmed is the flavor of the season. Many people are using dexmed. It's extremely popular. The internet is flooded with articles on the use of dexmed for procedural sedation. And this study is probably one of the largest series of procedural sedation using dexmed outside the OR. The authors have said that it has a very high success rate and does not yield a high incidence of adverse effects. Currently available agents have excellent safety profiles when administered in the correct dosages, under closed supervision, and with enough monitoring. Are there any adverse events that are likely to occur with sedation? Yes, there's a whole list of adverse events ranging from apnea, laryngospasm, and airway obstruction to hypotension, bradycardia. Occasionally allergic reactions and seizures have also been reported. What happens when you can't sedate? If you can't sedate with the routine drugs, when you increase the drugs, sit back, reassess, and take a break. Sometimes you may require an additional second sedative agent. You may need to reschedule the procedure, or you may need to progress from mild sedation to moderate sedation to even general anesthesia. Whenever you are in trouble outside the theater, it is advised that you step back, take a reassessment, and if possible, consult an anesthesiologist who will help you out in the procedural sedation outside the theater. This is to ensure maximum safety of children who receive sedation outside the theater. Are there any non-pharmacological means that can help? Yes, non-pharmacological means are complementary to pharmacological interventions and can help decrease the total amount of drug that is used for delivering sedation. These include behavioral and cognitive approaches such as desensitization, distraction, coping skills, positive reinforcement, and relaxation helps. Ability to access multiple modalities to engage numerous sensory pathways is what is responsible for a better outcome when you use these non-pharmacological means together with the sedative agents. Remember that whatever non-pharmacological means you are using, they should be age appropriate. You may use a favorite toy or a blanket in a small child. Some videos may be shown to these children. For older children, virtual reality glasses help. Movies and books have also known to help. Okay. In very small children, in neonates and infants, it has been shown that sucrose is a very effective non-pharmacological intervention. This study talks about glucose providing sufficient sedation for MRI in newborns without the use of any other sedative agent. I remember reading a case report in Anesthesia newsletter many years back where they had just fed the children, asked the mother to feed the child, neonates particularly, just prior to the CT scan. A hungry child would suckle on the mother's breast, become full and rapidly go to sleep, and the procedure could be completed without any other sedative administration. This is a picture which shows what is known as the dog therapy, where children are shown pictures of how a dog should lie on the MRI table. It helps them get prepared for what will happen to them when they are wheeled into the MRI suite. A mock MRI drill can be done and shown to children. Older children can be given virtual reality glasses to help them to visualize what they are in for when they are taken into an alien environment like the MRI suit. Any areas of controversy which we need to re-emphasize? Yes, as we've already said, the major area of controversy at the end still remains as to who can deliver sedation to children. Anesthetists, of course, but for non-anesthetists, there is a very large heterogeneity variation in the skills that they have before they give anesthesia or sedation to children outside the OR. You may have pediatricians delivering sedation. They are very well versed with drugs. Yes, it's a part of their PG curriculum to probably take care of children with airway problems, and they know pediatric resuscitation very well. At the other end, you may have dental surgeons probably who've had no official training on looking after pediatric sedation and the difficulties that it will cause. They still give sedation for children. So adverse events, it has been shown, happen irrespective of the physician type, but the complications are related to the skill set of the practitioners. The practice standards are also an area of controversy still. What constitutes an appropriate training? As I've just outlined, there's a wide variation on the training available to physicians in their curriculum before they can deliver pediatric sedation. Can we discuss pediatric sedation and the complications after a 2-day lecture and let them take care of all these sedation procedures in the periphery? A simple 2-day course based on mannequin, is it sufficient or not, is always a contentious issue. How do you discharge these children after procedural sedation? The child must be assessed and observed in a suitably equipped recovery area. Take care of the airway patency, the ventilation, cardiovascular and status. Level of consciousness should have returned to baseline. The child, if age appropriate, should be able to sit unassisted and should be able to take fluids without vomiting. The pediatric pads is a useful method to assess the suitability for discharge in children. A simple evaluation tool which has been outlined in this paper on anesthesiology talks about the ability of the child to remain awake for 20 minutes when placed in a quiet environment after the procedure is over. And another article talks about the fact that majority of the adverse events occurred within 2 minutes of the final medication dose, and that majority of children were ready for discharge from the emergency department after approximately 30 minutes of the last dose given for sedation. Whenever you discharge these children, make sure that they are accompanied by a responsible person. Responsible person means those who can understand the discharge instructions very well and can take care of feeding responsibility. It is also necessary when you're discharging these children that the accompanying person given the telephone number of a practitioner who can be called in times of distress. Anything new? Yes. Procedural sedation teams are now recommended, which consists of anesthesiologists and nurse practitioners which take care of all sedations as a team outside the OR. It has been obviously shown to be more efficient and safe, but it's obviously got a disadvantage that it's not practical in smaller centers and greatly increases the cost. The take-home message is that patient factors are key considerations for sedation strategies. Pre-procedural sedation assessment is important to rule out those patients who cannot be sedated outside the OT. Fasting guidelines for elective sedations in ASA grade 1 and 2 patients are now more liberal. At least 2 qualified physicians are required who can manage the airway and resuscitate the child. Capnography is today recommended as a monitoring procedure for PSA, and whichever sedative and analgesics that you use should be individualized, and the amount of drug delivered should be carefully titrated to the category of patients. Thank you very much for your patient listening. This is a child of Mobius syndrome. I have permission of the child as parents to display the photograph. This is a child we sedated only yesterday, scan for a diagnostic CT. Thank you so much.
Thank you so much, Dr. Anju ma'am. That was an excellent talk, very exhaustive and delivered in your inimitable style. Before we continue and take up the questions, I would like to place on record our appreciation for the other chairpersons for tonight, Dr. Poonam Motiani, Dr. Kavita Sandhu, and Dr. Sapna Patla. Dr. Poonam, would you like to take over now and ask any questions if they're in the chat box, or you would like to ask, please?
Yes. Good evening, ma'am. That was an excellent talk, and it's always a treat to hear you, like Sir said. And there are, I don't see any questions in the chat box, but there are a few things that you have very rightly emphasized, and one of them was the use of capnography. So, and you had categorized the procedures into diagnostic imaging, painful diagnostic, and painful therapeutic. There I would like you to add one more category, diagnostic imaging at a distance, because being in a cancer institute, we used to do a lot of diagnostic imaging from a distance. So patients placed in the radiotherapy suite where they will undergo diagnostic procedures. So capnography formed a very useful part of our monitoring at that time. We used to place the sampling line and place the anesthesia workstation in such a way so that we could view it from the monitor outside. Okay. And the other comment I would like to make, ma'am, is do you recommend IV placement of an IV prior to all sedation procedures?
Thank you, Dr. Poonam. Yes, I do. I do not because literature says it, but I've seen trouble happening without an IV line. No anyone from the surgical specialties, but dental surgeons in their teaching and training somehow are never taught that you need to put an IV line in a child before you inject local anesthetics in them. They give sedation, they give local, and they are not in the habit of putting an IV line. I don't think I can swallow that. It just doesn't sit right that you're delivering sedation to a child without having an access. You needn't give fluids, but an IV access is 100% required before you give sedation. I think that is one safeguard which we can all take, which we can all recommend, which we can all encourage. Just placement of a small IV line is going to take care of any trouble that may happen during the sedation procedure. Absolutely, 100%.
Yeah, I would tend to agree with you, ma'am. I think practically all of us as pediatric anesthesiologists would like to have an IV before we do any procedure. If I may just ask you, ma'am, do you have any partiality or any specific favorites or a regimen? For example, if you want to anesthetize a small baby for a CT scan, say a biopsy under CT.
Yes, sir. As I've said, there is a lot of talk about Dexmed. I'm also practically in love with the drug. Yes, I've used a lot of Dexmed. But after so many years, I've realized that if the child is small, you cannot keep him motionless with Dexmed alone. It does not work. You need to combine Dexmed with, even if you do it with a small dose of probably propofol, or that produces bradycardia, please remember, maybe a little bit of ketamine. By itself, Dexmed, which has become the favorite of so many people, does not provide enough, should I say, sedation to a child. Yes, there is anxiolysis. Yes, there is sedation. Alone, enough. In older children, yes, Dexmed works when you combine it well with a block or a local anesthetic. My journey with Dexmed, if I can take a minute, the first time I used it was for removal of a pin in a child. And I thought Dexmed will work, little local anesthetic, and Dexmed was being touted as such. The child jumped, and it was so unpleasant for us and for the surgeons. So it's by itself, it's not a good drug. Having said that, I still love a combination of drugs depending upon the patient's age, the procedure, the comorbidities, and what you actually need for that procedure. Propofol with midazolam, with ketamine, ketofol is a beautiful combination. Sometimes midazolam alone may be enough, But usually a combination of propofol, ketamine, propofol, midazolam works beautifully. And alone ketamine may not be a good drug. It produces a lot of secretions that can be a problem. You need to combine it with a little bit of midazolam. Nitrous oxide I haven't used for many years for sedation. It's probably for all of us a little outdated. So propofol in combination with midazolam, ketamine, little bit of dexmed works very well. I try to avoid opioids in the outpatient unless patients are there in our theater. We have in our kind of setup, I come from a pediatric hospital, we have days slotted, sir. We have like Tuesdays and days. All dental patients are slotted on a single day from morning to evening. Then we're doing their dental list. CT scans are all GA CT scans have been relegated to a particular day. So if the patient is coming to us in the theater, then there is no problem. Then you can use a wide variety of drugs. But outside, probably a combination in drugs is the best.
Okay, I think that's a very good idea, ma'am. I think combination of drugs is usually ideal, and good monitoring, like you said, and an IV.
Indrani ma'am wants to say something.
Yes, Dr. Indrani ma'am.
Yeah, two things I wanted to say. One is going along with Dr. Poonam, what she said, for radiotherapy and all those. One thing which I used to face long back was tachyphylaxis. I don't know whether, Poonam, what is your experience on tachyphylaxis, especially those kids who come repeatedly. For radiotherapy?
We haven't faced
goes
it,
on increasing.
It does, ma'am. We used to give them, we used to give them a mixture of ketamine and propofol. So we used to start a ketofol infusion for them.
Yes.
Induce them with ketamine, put in a nasal cannula, turn the anesthesia workstation towards the monitor and keep monitoring all the parameters and start the patient on ketofol. And they used to come repeatedly for weeks together. So we used to see tachyphylaxis in some of them, but not haven't really documented it, ma'am.
Yeah, it's known, ma'am.
And the second thing which I wanted to tell you was, in our institute, where we have CTs and MRIs, where we give procedural sedation, the children are not admitted. And that worries all of us, actually. They are not admitted. They come in the morning and they go back after they're fit for discharge. So what is your take on that? Because, we are doing it, and so far we have not had any catastrophe or anything, though we have had children who collapsed in the MRI suite, and maybe because of hypothermia or whatever, then we had to give fluids, warm them up nicely, the child came out and things like that. We've had such incidences, but we've not had a mortality. But it is always a sword, hanging on our heads. So what is your take on that? Do you think children should be admitted?
Can I answer that, ma'am?
Yeah, Dr.
Ma'am, this used to happen at our institution also, where we do so many CTs and we have now an MRI, and the children were never admitted. So we've had not a mortality, but enough morbidity. I've seen seizures, I've seen vasovagals, I've seen reactions, So what we now do is after a detailed, it has taken us a couple of years to do that. After talking to the administration, we get what is known as short admission made. We do not deliver, at least the anesthesiologist, the physicians are not doing it, but the anesthesiologists do not deliver sedation till the child is short admitted. So, because it makes a difference in the census, the administrators are very, very worried about all this. So we do what is known as short admission. That means they are admitted, they do the procedure, and they go home in the evening. But no anesthetic, no sedation by an anesthesiologist is delivered without an admission, not any longer.
Yeah, but if I may just add, ma'am, we also do the same in our hospital. We have what is known, we send them to the pediatric ward where they are detained till the evening. And then we send them home in the evening. almost no patient goes straight away from the MRI or the
Yeah,
CT.
they don't go. So we have a small, it's a makeshift in every place, in the CT scan, in dental room, we have a short, a makeshift PACU kind of thing where we make sure that a monitor is available. Then we make our postgraduates sit there and ensure that all the children, he signs the discharge forms.
Absolutely.
Child meets the basic criteria before he moves away from there so that they can eventually be sent home.
Correct.
Yeah, see, our pediatricians are very resistant to this kind of admission, So God forbid if something happens, then we have to admit them in the emergency. So that is our only
Ma'am,
You're
sometimes we go and we attend these calls. You must have also done this. These calls come from various parts of the hospital. You end up going there and realizing to your horror as to what is happening. We attended a call in a bronchoscopy room in the pediatrics department. And there was first time, couple of years back, we realized that rampantly pediatricians were doing diagnostic bronchoscopies under ketamine. They were not giving anything else. There was no monitoring, just ketamine. And when we found out, the morbidity was so high. We never knew this because they never told us, they were just doing on their own. So the less said about the physicians, the better. Only those places where we are called, we at least can make sure of some standard.
Don't talk about physicians.
Ma'am, it's very frightening.
He was doing plastic surgery residency. He calls me up and he's saying, for change of dressing, Mama, how much of ketamine should I give? I said, no, you're not touching ketamine.
So, ma'am, they're using propofol. Ever since they've realized that this drug is available, they're using propofol, they're using ketamine. I don't know whether they're using Dexmed outside the theater or not, but propofol, ketamine, and midazolam, they're definitely using.
Yeah.
In our setup, we have orthopedicians who used to give pedicloral to all children. So he used to not calculate the dose, just give one capful of the drug. So we had a little neonate who came back the next day. The mother came with the child and she said, he's not accepting feed since yesterday. And the child, even after 24 hours, was sedated. And the orthopedician called us and said, ma'am, do you think this one needs intubation? I said, if you would have needed intubation, we should have done it yesterday. Why didn't you tell us? So thankfully, the mother did not force feed the child and the child was okay. But we have...
Ma'am, BERA is done. The ENT people,
hemato-oncologists,
they do BERA in small children who are syndromic, who have so many other problems. They just make them drink sedative drugs and just do it and then send them home. It is the less said, the better, because it's very, very dangerous. We've at least told them, if you do anything, at least make sure that oxygen is available at hand. Many a times they don't even have a functioning suction apparatus.
Absolutely, ma'am. I think we all have horror stories to tell. And now, if you will excuse me, I'll have to cut short because this promises to be a very interesting discussion and it'll go on and on. And we have another talk, ma'am. So with your permission,
we have two questions in the chat box.
Yes. So 2 quick questions, Dr. Anju, ma'am. Number one is from Dr. Deepa, and she wants to know if the combination of midazolam and fentanyl is good for painful procedures.
Yes, it is, but I would try to avoid fentanyl outside. One, it produces a lot of nausea, vomiting. Secondly, you need more monitoring if you're giving an opioid. So if you need sedation and analgesia, probably midazolam with ketamine can be combined. That should be a good thing to do. Make sure you give fentanyl and monitor the child. It produces too much of nausea, sir. So the child we feed the children. The moment the sedation is over, they are awake. We make them, they have some fruity or something right in our presence. You won't be able to do that if you have too much of fentanyl.
Okay. And the second question.
Remifentanil is going to hit the market.
Yes, ma'am.
So that is going to do a lot of
wonders. Yes, ma'am.
Yes, it is. Especially those who want sedation and analgesia.
Somebody,
and Sanjay, Dr.
Sanjay Prabhu, Dr. Sanjay
for
Prabhu,
MRIs.
So Dr. Sanjay Prabhu was asked, what about any protocol for MRIs? Where of course,
no protocol, but I like to err on the side of caution. Like to protect the airway. One, the child is completely remote and away from you. The accessibility is definitely less. The procedures are long. There's severe hypothermia. There's a lot of issues related to MRI. I like to protect the airway. I prefer using a supraglottic device. I don't really intubate the trachea of these children, but yes, general anesthesia with protection of the airway with the use of supraglottic device is what I generally practice.
Yes, I think that's an excellent idea, ma'am. It's always better to establish the airway, and unless, of course, the child already has a tube because he's so ill.
Yes, yes.
So, with permission now, ma'am, we'll go on to
sir,
the next topic.
I would like, sir, Dr. Kavita Sharma, she wants to say something, sir, Madam Kavita.
Okay, okay. Oh, so sorry, Dr. Kavita. My apologies. Please,
No,
ma'am,
it's
please
okay.
ask. Please ask.
Dr. Navdeep, one thing I wanted to say, since we all anesthetists, we are dealing with many children for this sedation, and many of the pediatricians themselves or others are also doing it. Sometimes we get children where they have already tried giving a sedation and it did not work, and they send the patient to us. So whenever we are doing and the patient has come from another specialty, we must make sure that some sedation, if something has been given already, because they might not even document it sometimes. So when we start giving it, the patient has already received a lot of, sometimes multiple drugs and sometimes very high doses of drugs. So as anesthetists, whenever we are giving, we make sure that day the child is fresh, no sedation has been given by any other person.
Yes.
So that is one thing. And at MAMC, we had worked out that anesthesia or deep sedation is an inpatient procedure, not an outpatient procedure. So a short admission was always done. Rest, everything you people have already discussed beautifully. So
Okay, good, ma'am.
thanks.
Thank you. Those are very, very useful inputs and very correctly said and rightly said. So now we go on to the next topic. Thank you once again, Dr. Ranju, for that
Thank you,
excellent talk.
Thank you.
It's my proud privilege now to call upon Dr. Kavita Sandhu to conduct the next session. Dr. Kavita is Director and Head of Neuroanesthesia at Max Super Specialty Saket. She's the Program Director for ISNAC since 2014. She's a renowned neuroanesthesiologist and a caring and compassionate doctor. Over to Dr. Kavita Sandhu for the next session.
Good evening, everybody. Thank you, Navdeep, for that kind introduction. So after that excellent lecture on procedural sedation, we move on to perioperative fluid therapy. Now, this is an area that I think has been a great challenge for all anesthesiologists since time immemorial. Less glucose, more glucose, isotonic, hypotonic, so on and so forth. And I think that the debate is unending. And when we come to children, the room for error is so little that I think the challenge is compounded many times over. So to clear the cobwebs on this very controversial but very important topic, we have with us today Dr. Manish Gupta. He is a senior consultant at the Institute of Anesthesiology, Pain and Perioperative Medicine at the Sir Gangaram Hospital. He has been on the faculty at various national and regional conferences and a resource faculty for many workshops. He has many publications in both national and international journals, as well as chapters to his credit. His areas of interest include kidney transplant, pediatric anesthesia, airway management, and acupuncture. I think I have Dr. Sapna, who would be co-chairing this session with me from Safdarjung. So without wasting any more time, over to Dr. Manish Gupta.
Thank you, ma'am. Thanks for those kind words. And am I audible?
Yes, sir. You are very much audible. So please go ahead, sir.
Okay. At the outset, I would like to thank the organizers, Dr. Indrani, Dr. Dr. Vishal, and especially Major General Dr. Navdeep Sethi for giving me this opportunity to share my thoughts on this special topic with you. Sorry, I'm unable to share my screen. There is a message, host disabled participant screen sharing. So I'm unable to share my screen.
It's done, sir. Please now share.
Yeah. No, it's Okay. In any surgical patient, IV fluid therapy is considered the backbone of therapy, and in pediatric cases especially, it becomes more and more challenging as the margin of error is quite less, and in the intraoperative period it becomes a little more difficult because rapid fluid shifts are taking place. So traditionally, intravenous fluids have been given for providing water, energy, electrolytes, and it has been recognized without any doubt that they help in increasing the cardiovascular stability, maintenance of tissue perfusion, adequate tissue oxygenation, and serves providing electrolyte balance. But as it has remained a classical teaching that for every pediatric patient, we tend to give any drug in per kg body weight dose. So does it apply for the IV fluids also? Can we say that if a person of 60 kg body weight who requires 1000 ml of fluid in an hour in a particular situation, the child who is 3 kg will have just 20 times lesser than that, that is around 50 ml per hour? No, this is not the case, because there are some basic physiological differences between an adult and a child. So in the next couple of slides, I'll be discussing those physiological differences. A pediatric patient is having more water content in its body, usually 70 to 80%, as compared to their adult counterparts who have 60 or even lesser than that fluid. And if we look at the pediatric population in particular, a 28-week fetus has got around 80% of water in its body, which gets reduced to around 70 to 75% at term. And in the next 3 months, it further gets reduced to around 65% and goes on till the child becomes an adult. And during this period, the fat and the muscle content of the body gradually increases. And as you can see, the fat content in a premature is very low. So they have a tendency to lose a very large amount of water through insensible losses through skin. And this decreases over the term and future as they grow up. It has been very convenient to study the fluid dynamics by dividing the body in two basic compartments. One, the intracellular fluid compartment, the other extracellular fluid compartment. And extracellular fluid compartment is again divided into intravascular fluid compartment and interstitial fluid compartment. Whatever drug, IV fluid we inject, we are injecting in the intravascular compartment through the veins, which gets redistributed to the interstitial fluid first and then gets transported to the intracellular compartment. And if we look at the composition of these compartments, in a term infant, extracellular fluid and intracellular fluids are more or less same in quantity, which gradually shifts in the adulthood to more intracellular fluid in a person. As such, as the child grows, the whole content of the body water increases in any of the compartment. But if we see in the percentage terms, the plasma volume remains static at around 5%, but the extracellular compartment share gradually gets reduced. So this has an implication. If we give we have to give more fluid to a newborn as compared to an adult whenever we plan IV fluid therapy rather than adult patients. If we look at the electrolyte components, the extracellular fluids have a major share of sodium as a predominant cation in the extracellular fluid and chloride as major anion in the extracellular fluid, whereas in intracellular space, it is potassium, which is in a major quantity, as well as the phosphates, which are very high. That and whatever fluid we plan to give in whether in a pediatric patient or an adult patient, suppose we are giving a balanced fluid, balanced salt solution, the electrolytes that we inject, infuse in the body will get redistributed according to their respective location in the extracellular and the intracellular fluid compartment, and the water will follow to make the osmotic gradient as per the body's requirement. So if we give a balanced salt solution, if it predominantly contains sodium, it will go more to extracellular space. If it has more potassium content, it will go more to the intracellular space, and the water will follow. But if we choose normal saline instead, the electrolyte content is only sodium and chloride. So this will more or less remain confined to the extracellular compartment only. Here, I would also like to point out that proteins are mostly found in the intravascular compartment, as they are not able to cross the endothelial barrier and are unable to go in the interstitial fluid space. But in some disease states like sepsis and burns, and capillary permeability is increased, they can get into the interstitial fluid, from where they are promptly removed by the lymphatic vessels and again transported back to the blood. But as lymphatics work very slowly, this takes a long time. Another important concept is the concept of osmolality. It represents the number of solutes that is present in 1 kg of solvent. So all the fluids we give are usually measured in terms of osmolality, and the osmolality of blood is considered to be in the range of 275 to 295 millimole per kg. So if we give a fluid that is very much diluted, it means that osmolality is quite less, and higher value indicates that it is a more concentrated kind of a solution. When the blood osmolality increases, it activates the ADH and renin-angiotensin aldosterone system. The calculation of serum osmolality is, as you can see, this formula, this has been given in textbooks for a long time. The major share is that comes from sodium ion, whereas BAN and glucose, they of course contribute to the osmolality, but as they can cross the cell membranes, so their contribution gets very much reduced in this particular osmolality measurement. So it is the sodium mainly which constitutes the osmolality of any given solution or a blood. Next important thing is tonicity. It is the ability of a solution to move water across a semi-permeable membrane by the process of osmosis. If a solution is more concentrated, it will attract water from the other side. And if it is less concentrated, it will allow passage of water from its side to go on the other side. So a hypotonic fluid will send water to the other side, whereas a hypertonic fluid will attract water from other side. And if the solution we are injecting, the IV fluid we are injecting is isotonic, no net water movement takes place. There has been a considerable amount of literature coming up, which is recommending isotonic fluid infusion in children nowadays, as there was a previous tendency to give more and more hypotonic fluid in the pediatric population. But why so? I'll be discussing in the next few slides. And traditionally, we have used 0.2% saline with dextrose, 0.45% saline with dextrose, Isolite P in pediatric patients. And in this particular list, I have kept ringer lactate on both the sides, because actually, if we see the composition of ringer lactate, it is a slightly hypotonic, but people are using it with a little bit of addition of dextrose nowadays. So that makes it almost isotonic. So purposefully, I have kept it in both the lists. And plasma light is another isotonic fluid that is quite popularly used nowadays. Normal saline, on the other hand, is used for ages, but is now a little bit discouraged as it can cause hyperchloremic acidosis. Hypertonic fluids are rarely used in anesthesia practice, except for some trauma victims, especially the pediatric patients or adult patients who have traumatic brain injury. In those cases, hypertonic fluids, 3% saline is used, although it can cause hyperchloremic acidosis, but it has been seen that it causes a better cerebral perfusion pressure by decreasing the ICP, and sometimes more found to be more effective than mannitol itself. There is another consideration of blood volume in children. Premature neonates have 100 ml per kg of blood present in their body, whereas this volume decreases with age. The term neonate has got 90 ml per kg, infants 80 ml per kg, and grown-up children has got a further decline, and they have 75 ml per kg. Although it has been traditionally said that if there is 20% of blood volume is lost, we should transfuse blood. But latest German guidelines say that in case if volume is only the concern, one should not go ahead with blood transfusion or blood product transfusion. We should use colloids instead, unless until the oxygen carrying capacity is in question. Now, coming to physiological changes in the organ systems that takes place, that makes the pediatric population different from adults. A term infant has got hemoglobin of fetal type that has a little more affinity to the oxygen and has got less affinity of offloading oxygen to the tissues. So this makes the term infant and have more chances of hypoxia as compared to the adult patients. And it takes about 6 months for the term infant to gradually shift from fetal hemoglobin to adult type of hemoglobin. Transfusion trigger, again, I said that nowadays it is suggested that we should discourage giving blood to the children as we discourage it in adults, and one should avoid giving blood up to 9 gram per deciliter of hemoglobin, but some people say it is 8 gram per deciliter. There is no final consensus of how much it should be given. Even the German guidelines say that one can go up to 7 gram per deciliter if the patient is stable and there is no further loss of blood expected. Now coming to the cardiovascular system, which has to deal whatever IV fluid we are going to give. As soon as the birth takes place, there is elimination of low resistance central circuit, and body is shifted to high resistance pulmonary and systemic circulation. In term infants, cardiac output per kg body weight is the maximum, and tachycardia is the sign that cardiac output is increasing, and bradycardia reduces the cardiac output. So in pediatric patients, it is whatever we do, whether we give more of fluid or we give less of fluid, they usually respond with heart rate variation rather than any increase in blood pressure or decrease in blood pressure. Blood pressure changes are a late sign, and it is very difficult to define hypotension. There is no consensus as yet how much values should be said as hypotension in pediatric patients. Although most of the people agree that 70 to 90 millimeter of mercury is the thing, and but most of the international guidelines say that international guidelines show a lot of variation and do not agree for a same value. As the myocardium is incompletely developed and immature sympathetic nervous system along with it, this makes these patients more susceptible to tachycardia induced increase in cardiac output. Hypovolemia also causes tachycardia. That's how these pediatric patients compensate. And since the nervous system is not well developed, sometimes predisposed, any high vagal tone is also found in these particular patients. That makes them very prone for sudden bradycardia in the OT, and sudden anesthetic depression should be avoided in premature or term neonate. Coming to the next, renal system. The renal system as such gets a very reduced cardiac output share as compared to the adult, which receives about 25% of the cardiac output to the kidneys. And that results in a decreased GFR and low excretion of urine. For the same reason, the tubular absorption and secretion is also reduced in pediatric patients, especially during the few early days of life. And there could be excessive tubular loss of bicarbonate, which can tilt the balance of the blood towards more acidic in these patients. If we see the GFR is quite low on the first day of the birth and gradually increases, and it takes about 3 to 4 years to reach an adult level. And if creatinine levels, although they are lesser in cases of infants, but the creatinine clearance is also low as compared to adults for the first few days of life. Now, these concentrating capacity in that allows them, that makes them very much difficult to tolerate hypovolemia. A premature newborn can only handle dehydration 4 times less as compared to the adult kidney, because adult kidney has got 4 times concentrating ability, and infant also has got half the concentrating ability of the urine. On the other hand, diluting capacity in a premature newborn is almost as much as an adult, but in infant, this capacity is covered. Sorry.
Continue, sir.
The large surface to weight ratio, high total water content, and limited renal ability to concentrate makes these patients more susceptible for hypovolemia induced decompensation and greater insensible water loss from the skin and high GFR as which results in there is some disturbance.
I think we have to unmute everybody.
High GFR results in sodium.
Please unmute yourself, sir. Dr. Manish, sir, please unmute yourself, sir. Please unmute yourself.
Dr. Manish, you're not audible.
Yeah. Now, am I audible?
Yes.
Yeah, you're audible now.
Okay. And all these three changes makes these pediatric patients more susceptible to hyponatremia, glycosuria, and there are increased chances of bicarbonate loss. So another important thing that we should consider about pediatric population is anti-diuretic hormone, which is very much required for maintenance of osmolality, and in due to various reasons that are present during the perioperative period, there is increased ADH secretion. Sometimes these things are in the hand of anesthetists, and many factors that are not even in the hand of anesthetists. So plasma ADH concentrations which are less than 1 picogram per ml at plasma osmolality of 280 milliosmoles per kg, and at maximum antidiuretic activity, which is they rise up to 5 picogram at osmolality of 295 milliosmoles per kg. So what effect does it have on a patient? Due to increased ADH secretion in pediatric patients, there is decreased urine output during the perioperative period, which can continue up to 5 days post-operatively. So the tendency of the pediatric anesthesiologist is to give more and more fluid. And as we were using hypertonic solutions as a practice, this led to a lot of cases of hyponatremia in these particular patients, which was sometimes having very lethal effects on these subjects. Both ADH and angiotensin II, they mediate the, they control the further requirement of fluid, and after a certain stage, only fluid supplementation is the way to decrease the concentration of ADH levels and angiotensin II. Now, there are some other causes which needs to be taken care of during giving anesthesia to these patients. Hypovolemia, hypotension, hypoalbuminemia, these can be controlled. Of course, cirrhosis and congestive heart failure cannot be controlled by ourselves. Any condition like hypoxia should be minimized. It leads to increased ADH secretion and release. Pain, post-operative nausea, vomiting, stress, and sometimes some drugs, even narcotics, can increase the ADH release. So there was, one should be able to recognize and diagnose the signs of hyponatremia that can take place in a patient under in a pediatric patient undergoing surgery. And if you see the list, these are very commonly encountered in the post-operative period: headache, nausea, vomiting, confusion, disorientation. And they are very much confused because most of the time when some sedatives action is sedatives are having prolonged action, you can have the same type of symptoms. So at any suspicion, one should check the sodium levels as early as possible. There was an article by Arya Patel in a British Medical Journal in 1992, in which they reported 6 cases of death and 9 cases of cerebral developmental disorders after giving hypotonic solution to that developed after giving hypotonic solution to normal patients in the hospital. So recognition of hyponatremia at an early stage is a must, and in that case only we can save these patients from undergoing the catastrophic cerebral brain damage. Central nervous system in these patients is also having poor autoregulation of blood pressure. Intravascular status, of course, has a profound effect on brain function. Usually a sudden BP rise is not present in pediatric patients because their arterial system is a little bit distensible as compared to the adult persons. Hypotension, of course, can lead to cerebral ischemia and should be avoided as far as possible. And cranial reflexes are poorly developed, especially the chances of vagal stimulation are very high in these subjects. So that can predispose them to having bradycardia, and consequently lower cardiac output can be there. Coming to the hepatic glucose homeostasis, liver of these term infants has got large reserve of glycogen, but the ability to convert this glycogen to glucose is very less, as the necessary enzymes are lacking, and this takes some time for these term infants to develop these enzymes, which can be 12 hours or sometimes even 1 to 2 days. So these this patient population is very prone to hypoglycemia, and that's why it has been a traditional practice to give hyperglycemic IV fluids to these particular patients for 1 to 2 days. So this chart shows the traditional fluid therapy that was given to these patients. At first day, 10% dextrose was supplemented at a dose of about 20 to 40 ml per kg per day. And this was continued for first 3 days, while from the second day, some saline was added. And that this was for the reason that for the first day, most of the infant do not had the capacity to excrete sodium adequately. And from the second day onwards, when some physiological diuresis leads to this loss of sodium, only then it was advised to supplement the pediatric patient at this stage with saline. And gradually, as they go on increasing the age and weight, then more and more saline was added to these solutions. So traditionally, it was for any pediatric case, it was practice to assess the deficit in a patient, estimation of dehydration severity and rapidity, determination of fluid deficit type, and to plan the how much fluid of what type should be given to these patients. And maintenance therapy was, of course, I'll be discussing in later slides, and a replacement therapy was also planned for ongoing losses. Then as far as dehydration is concerned, some special requirements are posed by special requirement are posed by certain individuals. having fever, the requirements go very high. 12% is added for every degree of centigrade rise in temperature. In cardiac failure, of course, one has to see how much energy should be given and how much fluid should be reduced or exceeded. In other surgeries, burns, sepsis cases, the requirements go very high, and this should be taken into account whenever we decide the deficit part. Now, if there is losses in terms of vomiting, it should be seen that what content is there in the vomiting. If it is gastric, then sodium content is very low. If it is intestinal content, sodium contents are considerably high. Even in cases of diarrhea, sodium content is quite low. If the potassium, if it is an ileostomy stoma present, then the potassium loss is quite high, and chloride is lost mostly in cases of chloride content is lost very high in very high quantity in gastric secretions, and in considerable amount, of course, in intestinal secretions, but very low in cases of diarrhea. Bicarbonate loss is more predominant in intestinal secretions. So in assessing the type of dehydration, one should consider whether it's hyponatremia or hypernatremia that is present. And the most important thing is, if there is a prominent clinical signs are present, that indicates more chances of hyponatremia. But if it is only a little clinical signs of dehydration are present, it is mostly because of water loss present. Then for postgraduates, it is important to note that various vital signs and signs of dehydration should be noted clinically before taking up any such patient for surgery. The amount of deficit should be decided, and that one should see anterior fontanelles, skin turgor, sunken eyes, mucous membranes, capillary refill, and all these should guide us to ascertain the deficit present in the child. Now, this chart shows the degree of dehydration that should be calculated. And I think it's most of the MBBS stuff which we'll be revising, but very, very important when assessing deficit in a pediatric patient. Now, in earlier days, so it was fluid administration strategy was that and how much fasting a patient is, that should be taken care, that used to be taken care of. Excessive losses of any kind, and it is still the same if the patient is on prolonged fasting. Of course, fasting guidelines have changed quite a bit. Calculating a maintenance requirement for water, energy, and electrolytes separately was planned, and estimating ongoing fluid losses during surgery in the form of hemorrhage, identifying additional derangement in the sense of insensible losses, hypoglycemia, hyperglycemia during the procedure, head injury, and any other complicating factors like head injury, birth asphyxia, etc. should change our management. And it was a customary to assess the post-operative requirement, and especially in those patients who had stoma present in them. So the post-operative losses were very high in such patients. And it was a customary to decide whatever we should plan should be according to that. Now, coming to the glucose management, as we know, hypoglycemia and hyperglycemia both are disastrous for these group of patients. And nowadays it is advised that one should do periodic blood glucose measurement, as it used to be done in diabetic patients, especially those who are coming with prolonged fasting, or for those who are having a prolonged surgery duration. 5% dextrose solution intraoperatively causes more hyperglycemia, so should be avoided. Nowadays, it is a recommendation that we should stick to 1 to 2.5% of glucose solutions in the intraoperative period. And it is advisable that one should continue any infusion that is ongoing coming in a patient coming from the ICU at the same rate or at a slower rate if required. Ringer lactate and isotonic fluids generally are sufficient for short procedures without glucose, but glucose can be added if the requirement arises. Now, excessive third space losses are still controversial. Some people recommend that it's of no use correcting the excessive third space loss. We should not consider them, as they are not going to come back to the intravascular compartment, and we should not supplement. But the literature says that we should see if there are excessive third space loss, especially in cases like necrotizing enterocolitis, where as high as 50 ml per kg per hour may be required to take care of this much of losses. In cases of massive ascites and other losses, we should consider. Now coming to the how to detect fluid overload in case if more IV fluid is given to the pediatric patient. Prominent veins, flushed skin, increased blood pressure. Although increased blood pressure is a late sign in pediatric patients, loss of the fold of upper eyelids, conjunctival edema, bilateral crepes in chest. These should be taken care of, and any decrease in serum sodium if we are going to do the PAC, or at that time we find that serum sodium is decreased. Instead of saying that chronically this sodium was low, one should check whether this child is receiving any hypertonic solution, which is the culprit. So coming to the maintenance fluid requirement, it has been a long practice where we used to follow the Holiday and Cigar formula, that is also known as 4-to-1 rule, in which for first 10 kg patients having up to 10 kg body weight, we used to give 4 ml per kg per hour, and for the next 10 to 20 kg we add another 2 ml per kg per hour to this 40 ml. And if the weight of the child was more than 20 kg, this 1 ml per kg per hour used to be added to this 60 ml, and that's how we used to calculate the per hour requirement of the patients. And the Holiday and Cigar actually derived this formula because they calculated the energy requirements of the pediatric patients, and came up with the fact that 1 calorie requires 1 ml of water. 1 ml of water is required for one metabolism of 1 calorie. And they also said that sodium required should be taken into account as 3 milliequivalent per 100 kilocalorie per day, and potassium requirement 2 milliequivalents for per 100 kilocalorie per day. They also talked about chloride requirement, which was not given much thought about. But the problem with the Holiday Cigar formula is we straight away adopted this particular formula and extrapolated that although it is a maintenance form guide for giving IV fluids, we took it also in the intraoperative period, where losses were also concerned, taken care of by using the same formula. Same fluid was used for taking care of losses, and that led to more and more cases of hyponatremia, as hypotonic solutions were used at that time, and more cases of hyperglycemia, as these kids were receiving dextrose, 5% dextrose in most of the patients. Now, there were some other pitfalls of Holiday and Cigar, that they did not consider preoperative fluid deficit in their calculations, as they actually came up these formula for maintenance of fluid in patients admitted to the ward. And they also not considered surgical blood losses, third space losses, and there was no special consideration for ICU or cardiac or renal patients, or cases with increased temperature or patients having hypothermia. So these all factors naturally led to more cases of hyponatremia, stress-induced excessive ADH secretion. Hyponatremic encephalopathy became much more commoner, although less recognized till the paper presented by Arif et al. In 1992, in which they highlighted this particular brain damage.
Dr. Manish, I would request you to start wrapping up your talk. We are running out of time.
Okay, sure, ma'am. Furman et al. And Berry et al. Later on advice for calculating preoperative deficit in these particular patients, which was so as to take care of the preoperative fasting. And recently in 1999, there were changes in the preoperative fasting guidelines were introduced, which reduced the clear fluid timing of fasting. And it was advised that clear fluids can be given till 2 hours prior to the procedure, and breast milk for 4 hours. Although in 2019, European Journal of Anesthesia has decreased it further, and in 2022, they have come up with a consensus that clear fluids can be given up to 1 hour prior to surgery, and breast milk up to 3 hours prior to surgery. Guidelines from Germany came in 2011, in which they stressed about decreasing the chances of hyponatremia and hyperglycemia in this set of patients, as there were disastrous consequences of these. And later on in 2017, they advocated of reducing perioperative fasting as far as possible, and simultaneously also advocated to reduce the post-operative fasting. This also added that there is no need of IV infusion therapy if the fasting is less than 1 hour, and if the procedure is also very short, and patient can be allowed to feed easily after as early as possible. So and they also recommended balanced isotonic electrolyte solutions with 1 to 2.5% glucose for deficit correction, and balanced isotonic electrolyte solution without glucose for maintenance. Regular RBS monitoring was recommended for long surgeries. Colloid use was advised only for cases where crystalloids were unable to maintain hemodynamic stability. Small boluses of low molecular weight of colloids was preferred and a restrictive approach was allowed. The hydration status was advised that hydration status should be assessed by clinical examination, auto transfusion maneuvers like passive leg raising test, and if required ABGs, and use of syringe or infusion pump for infants and burettes for older children are recommended in these guidelines. Then there are guidelines from American Academy of Pediatrics guidelines. These are applicable for patients who from age of 6 to 18 years, and there is a class 1A recommendation is there for maintenance fluid, which should be isotonic, and they also said that KCl in appropriate dose should be added along with dextrose in appropriate dose, although they do not specify how much dextrose should be added. And they also say that dextrose present in the solution affects osmolality but not tonicity. Hyponatremia affects all the hospitalized children, 15 to 30%. And if we infuse normal saline in these patients, that this does not lead to significant acidosis. No evidence of hyponatremia with isotonic fluids is seen easily. There is no mention, although, of how much percentage of glucose should be given to these patients. Then NICE guidelines were introduced in 2015 and later on revised in 2020. They stressed on history, clinical evaluation, and also investigations. In particular, plasma electrolytes should be monitored in every patient on a daily basis who is receiving IV fluids of any kind. And fluid resuscitation should be given in boluses of 10 to 20 ml per kg of crystalloid solution with sodium in the range of 131 to 154 millimoles per liter. That makes it restricted to only plasmalite and normal saline. Maintenance should be restricted in case if water retention is suspected, and replacement and redistribution should be done by isotonic saline, so isotonic IV fluids only. Hypertonic fluids, according to them, is recommended only in case if hypernatremia is documented, and that too it should be able to cause a sodium fall less than 12 millimole per liter per day, not faster than that. Now, the recent NICE guidelines also mention about the first few days of pediatric patients, how much and what type of fluids should be given to them, although no other guidelines mention this. And they have categorically said that these first few days guidelines are based on expert opinions of people who are working with these kind of patients, rather than actual evidences from the randomized trials. And they recommend only isotonic fluid along with good amount of dextrose added to it, instead of earlier hypotonic fluid that was advised for these kind of patients. They also particularly mention about how the hyponatremia that has developed due to hypotonic saline infusion should be treated in case if the need arises. First, they say that one should seek expert help. Somebody trained in such cases should come and assess such patients. If that person is not available or takes time to come, you can give 20 ml per kg of bolus of 2.7% normal saline over 10 to 15 minutes. If symptoms persist, then it should be repeated again with same time frame. If symptoms still persist, check sodium levels again. And if still low, one should repeat 20 ml of per kg boluses over 15 minutes for the third time. And then one should measure plasma sodium levels at an hourly basis, because the consequences of such a condition can be disastrous, and one should not exceed 100 ml limit with these patients. Now, even the IRAS Society of World Journal of Surgery, they also advocate to avoid give isotonic fluids with glucose, and they have specifically said that target glucose should be in the range of 60 to 126 milligram per deciliter, and hyperglycemia is considered at a value of more than 145 milligram per deciliter. And in other neurosurgical cases also, it has been seen that if hyperglycemia more than 150 milligram per deciliter is reached, it is seen as a bad prognostic indicator leading to a lot of morbidity and mortality. So one should avoid hypertonic solution, which can lead to hyponatremia. The Suppleman et al. Sums it up very well that one should give a background solution with balanced solution plus 1 to 2% glucose for as a bolus in 10 ml per kg per hour, which can be repeated as per the requirement. Fluid therapy should constitute of balanced solution, preferably they have mentioned Plasmalite at 10 to 12 ml per kg per hour. Volume therapy should be given only in case if need arises when crystalloid cannot are unable to maintain the hemodynamics, and any colloid can be given at a rate of 5 to 10 ml per kg per hour with a maximum limit of 50 ml per kg that should not be exceeded in a day. And a transfusion of blood and blood products should be reserved for special situations where oxygen carrying capacity or coagulation profile is in question.
Dr. Manish, please try and wind up soon. We are already running very, very short on time.
Yeah, no, I'm just summing up. But the indications of hypertonic fluids are also still there. Nephrogenic diabetes insipidus, severe burns, voluminous diarrhea, hypernatremia due to other causes, and conditions resulting in free water deficit should be treated with hypertonic solutions. Colloid requires special mention, and albumin is still considered gold standard, but gelatins and HES are equally effective. But all these colloids should be avoided in neurosurgical cases where the effect of administering these colloids could be disastrous. Balanced salt solution colloids are preferred in comparison to the one which are having normal saline in combination with colloid, and they may impact the coagulation. Some practical tips for the student: always get rid of air bubbles in syringe and IV set. Use flush syringe for drug injection to negate dead space present in IV set. Warm fluids should be given to the pediatric patients as they are very prone for hypothermia. Volume of injection should be added to fluid administered, and always administer fluid volumes through syringe pump only, or in older children's burette can be used. But in spite of many guidelines that have come up, some basic questions still remains. So guidelines can keep on coming. They will keep on addressing the issues at hand, and it is my personal advice that one should stick to the basics and use your own judgment to decide what fluid therapy is best for the patient. Thank you all for your patient listening.
Thank you, Dr. Manish, for that very exhaustive lecture. I'm sure there are a lot of questions, and to address these queries and comments, I now hand over to my co-chairperson, Dr. Sapna Batla. I think she is known to most of us, but for those who don't know her, she is the Associate Professor of Anesthesia at the VMMC and Safdarjung Hospital here in Delhi. And she has also been the ex-head of Department of Pediatric Anesthesia at the Chacha Nehru Bal Chikitsalaya, and she is a very active member of IPA. Over to Dr. Sapna, please.
Thank you so much, ma'am. I thank Dr. Manish, sir, for such an exhaustive and elaborative talk. I know there's a lot more to discuss in this challenging topic, as Dr. Kavita rightly said in the beginning itself, that this is a very challenging topic, and there's a lot of queries are there amongst the residents, what to give, how much to give. So I think there is a lot of scope further to discuss many things, but time is a limit. So we apologize, sir, to you. We had to ask you to wrap up soon because of the shortage of time. And thank you once again. And I think we can take up one or two questions if there is any in the chat box. I don't find any question, ma'am. So any comments from anyone?
Yeah, fluid therapy is now, dynamic indices have to guide fluid therapy.
Yeah, definitely.
We've already
target control. Yeah.
Yes. Yeah, dynamic indices. But leg raising is passive leg raising is mostly for adults, because the auto transfusion which you get in a pediatric patient, minimum you should have at least a 300 ml auto transfusion, which is not possible in pediatric. But probably, if you can do an abdominal compression and check the cardiac output.
Compression of the liver is also recommended, and passive leg raising has been recommended by German guidelines. And if that does not suffice, they say, and in major surgeries, we should go for ABGs to ascertain the fluid.
Yeah, then we have other indices like stroke volume variation, pulse pressure variation, variability index. All these are also there for measuring the dynamic indices.
Yeah, but the studies that are in pediatric cases are very limited for stroke volume variation and pulse pressure variation. So maybe in future, if such studies come up, then we can decide further about this patient.
May I just make a comment? Dr. Indrani ma'am, a very pertinent point about dynamic indices. Only catch is, suppose we don't have an arterial line. How reliable are the non-invasive indices?
See, arterial line, you need arterial line for all these things. So that is why I said, otherwise, if you can have ultrasound, then that will give you an accurate, especially the aortic root velocity. That will give you the most accurate of them all. But then having non-invasive cardiac output monitors in children, it has come down. We do have, I think, starting with M, the one which has come more something has come down. Yeah, we have a non-invasive cardiac output monitor in pediatrics also. So it has come down, and we can measure, but that is the only thing. But otherwise, if you have an arterial line, then you can do all this.
Then you have more variation. You have more flexibility.
Pulse pressure variation. In fact, some of them, if the child is on ventilator, if you are ventilating the child, giving IPPV, especially this is true for ICU patients, you can even increase the tidal volume. You can, it's like what do you call the 40 centimeters for 40 minutes. You can give a inspiratory hold, and you can measure the change in the pulse pressure.
As a surrogate.
As a surrogate, yes.
Quite true.
Also, even perfusion index by itself, why go for all that? Perfusion index also is a surrogate of a dynamic indices.
So, Dr. Ranju has got a hand up.
Sir, you asked about non-invasive hemoglobin monitor. A monitor is being launched by Massimo, which has a sensor for neonates also. pediatric patients and neonates. My experience is limited. I've seen the demo a couple of times, but I'm not very sure how accurate it is for neonates where you actually need the maximum accuracy. But this
You're using it, ma'am.
available in the Indian market. I don't know. I haven't used it myself.
We have it. We have it.
Okay,
and
okay.
We have been using it
Okay.
for the last 5 years.
Okay, ma'am, is it accurate for neonates?
Yeah, it is good. It is good.
Okay.
Okay.
Yeah.
You're quite happy with it, ma'am?
Yes, yes.
Because we are supposed to
sure
buy
of
it.
it.
So we were looking at inputs, whether it's actually useful for neonates and infants or not. Because
No, it is very useful.
okay, done. See,
You also get ORI in that,
Okay.
yes, we do, ma'am.
which is
Yes.
very important for children.
Yes.
Dr. Kavita, are you also using any of these monitors in neuro?
I just was coming to that, and I wanted to ask as to why there is, I mean, I really don't know the answer. You're all very experienced. I just want to know, in your experience, I mean, how much do you rely on invasive monitoring for hemodynamics? Because in our setup, because we are doing these long neuro cases that last 10 hours, 12 hours, 8 hours, lot of upheaval, blood loss, fluid losses. So we always have invasive lines in place, and we tend to fall back on invasive hemodynamic monitoring. Is there some special reason why it hasn't seemed to have gained that kind of popularity in pediatric anesthesia as it is so in the adults group? So maybe somebody can enlighten me on this. And second query was that, I mean, how many of us have shifted to the use of, the balanced salt solutions, plasma light, Cabilite, Sterophundine, and left ringer behind for children? So these are two queries which I just wanted to know from the house. We have very experienced people here.
Ma'am, actually, plasma light and Cabilite, in fact, they are the same fluid. We are using a lot of it, and of course, ringer lactate also. Sterophundin actually has calcium in it as ringer lactate. So whenever we need to avoid calcium, then we choose Cabilite, plasma light. And whenever we can safely give calcium, or we want a little bit of more calcium to be given, then we choose a ringer lactate or sterophundin in such patients.
Okay. And regarding the invasive hemodynamics, because what happens when there is massive blood loss, especially like we face in neuro, at that time, you're totally at sea if you don't have your lines in place, or you don't have a monitor to guide you, because the NIBP will give way, SpO2 will stop functioning properly because the baby becomes cold or totally hypovolemic. So then what do you all fall back on? Then I just want to know, for those who don't have arterial lines or central lines in place.
No. In most of the cases, when it is anticipated that in a major surgery of long duration where losses are going to be high, then we, of course, go ahead with central venous monitoring and arterial pressure monitoring. But in every case, we don't do it.
No, I wouldn't think so. But say when I know that there can be trouble, then I still am not very certain as to why invasive hemodynamics
one reason
on the ladder when it comes
everybody
to
is not that comfortable putting an arterial line or a central venous line in a pediatric patient.
All right. No, but going forward, I understand that limitation. But even I find studies also, there are very few, or maybe I am ignorant about it, when it comes to, the spectrum of invasive hemodynamic monitoring. Whenever it comes to children or neonates, I find very little matter available in literature. Is
No,
there
actually, there are very few randomized studies, and so the most of the guidelines, they just mentioned that evidence for this is not very much. So we are not giving any.
Dr. Manish, maybe Dr. Ranju, would you like to comment on this topic we are discussing?
Sir, invasive lines are difficult to put in children. It's very simply. It's easier said than done. A 1 kg neonate who comes to you with NEC, it is next to impossible to put in an arterial line and maintain it. You may be able to do it intraoperatively, probably, but maintaining it postoperatively is not an easy job. That is the reason we, look forward to non-invasive monitors. And it is not very common that we have invasive monitoring even for sick children. Because of these, it's very difficult to put in a line, ma'am, and you will not get a cannula which you can insert in the artery of a 750 gram neonate, 1000 gram neonate. It's very difficult to do.
Yeah, I totally agree with you, Dr. Ranju. But my next query is then why not more place for non-invasive monitoring?
Yeah,
You know,
absolutely.
I mean, maybe
So
there is a need for more research.
Yes, there is. There is.
There
That
is
is probably the
definitely.
reason all of us are.
Totally
Yes.
accepted, and I know we all are struggling. But I think that
I think with ultrasound, if it is at any 2 kilo child and above, we are comfortable putting lines.
so you have a good experience with that. So I think that's a very
We
good
have
thing.
ultrasound, so ultrasound guided lines are there, but not 750 milligram and 1 kilo.
And we have these NECs,
Like for example, biliary atresia, we put lines. So, and it's all ultrasound guided. So we do put it.
I think that's a mistake because most hospitals today are getting ultrasound. So I
yes, ma'am.
For all the budding pediatric anesthesia.
Now pediatric lines are fairly commonly available.
Yeah.
Central lines. Central lines. Yeah.
Thanks to the ultrasound, it's routine to put lines in major surgeries now.
Yeah, but in my experience, I find it sometimes even equally difficult to put an central line or arterial line, even with the use of ultrasound.
Yeah, that of course is there.
So maybe, sir, the more important reason may be the technicalities involved. No, we don't have that probe specific for the child mostly. So we cannot actually do with a bigger probe because this child is in any case very tiny, and if you put a normal probe, it may be really difficult to spot in the right sense. So
probe is one thing, and we have to position the child properly. Sometimes positioning makes a lot of difference. We are able to take the introducer to the a particular level, but negotiating of the wire and everything, that is sometimes much more difficult in pediatric patients.
Absolutely right. Thank you, Dr. Manish. And with the permission of the House, I think, can we call an end to today's scientific proceedings? You know, we've had some excellent talk. We've had excellent chairpersons and a wonderful audience, which is, still quite high, I find, So that, of course, speaks volumes for the quality of the talks today, Excellent academic content. Both Dr. Ranju and Dr. Manish, I would like to compliment you.
Thank you, sir.
Very well done. And our chairpersons for their excellent conduct.
Sir, can we have final comments from Dr. Tej?
Yes,
sir.
That's what I wanted you.
Over to Dr. Tej, call please, sir.
Thank you. Thank you. Nothing more to say except that both the speakers are superb and excellent, very informative, particularly Dr. Ranju.
Thank you, sir.
Who made it easy, because I think almost everyone has experienced one or the other things what Dr. Ranju has spoken. So when things become like that, the talk becomes very interesting. And I have a suggestion for the organizers to be very clear about the time allotted to the talk and the time allotted to the speakers, so that we finish in time and everyone remains interested for whole of the session and not one goes in between. And this is just my own personal suggestion.
Yes.
So thank you. Thank you, the president, the secretary. It is all because of them, Dr. Sethi, for having organized this webinar, all speakers, all persons who attended to it. God bless you all. Long live RSSCP.
Thank you, sir.
Thank you, sir.
Thank you, Major General Sethi, sir. Thank you, sir.
Thank you, ma'am. Thank you so much.
Good evening. Good night.
Good night, everyone. Thank you, everyone, for joining.
Thank you, ma'am.
Thank you, ma'am. Thank you, everyone, for joining today and staying awake for